Okay, let's unpack this. Imagine having energy that, well, it just feels limitless, right? Your mind's buzzing with brilliant ideas, maybe too brilliant,
Mm-hmm.
and this huge confidence, you feel like you can genuinely do anything.
Yeah.
Now, take that feeling and just amplify it way beyond just happy. It goes on for days, maybe weeks, and starts getting, well, out of control,
Yeah.
affecting everything.
It's a state that's really fundamentally different from just being in a good mood. It's a distinct period,
Yeah,
an abnormal, persistent change that really impacts how someone functions.
exactly. So today we're doing a deep dive specifically into that state, mania. We've got your revision notes right here, the material you wanted to get a handle on.
Mm-hmm.
And our mission really is to go through these notes together, pull out the absolute core stuff, make sense of it all, and lay it out clearly for you. High yield. Think of it like prepping together using your map.
Yeah, we'll hit all the key areas in your notes. We'll cover the definition, the causes, right through to diagnosis, managing it, and what the outlook might be. The goal is to really highlight those crucial points so they stick.
Perfect. So let me dive right in with the definition. Based on this material here, how do we precisely define mania?
Okay, so this material defines mania as a distinct period. That's important. The mood is abnormally and persistently elevated or maybe expansive or even irritable.
Right.
And the critical timeline here, the thing to remember, is it has to last for at least 1 week.
And it's not just the mood itself, is it? The notes list quite a few other key features that kind of come along for the ride.
That's right, yeah. Alongside that mood change, there's this significantly increased energy and activity level.
Sure.
And you also see symptoms like impulsivity, a really heightened sense of self-esteem, maybe even grandiosity.
Believing you can do anything.
Exactly. And a decreased need for sleep. They might feel totally rested after just, say, 2 or 3 hours.
Yeah.
Racing thoughts are common too.
Mm.
And often, excessive involvement in reckless behaviors, things with potentially bad consequences.
Mm.
And the notes explicitly state this causes marked impairment, socially, at work. It really disrupts things.
So it's definitely not just feeling good or energetic. It's hitting a level where it seriously messes with daily life. And this state, it's often part of a bigger picture, diagnosis-wise.
Precisely. The material really emphasizes that a manic episode is a key symptom. It's actually a diagnostic criterion for bipolar affective disorder.
Okay.
Its presence, often, alternating with depressive episodes, is really fundamental to diagnosing bipolar disorder. It's also noted that insight awareness of their own behavior is usually impaired during mania.
Right. They might not realize anything's wrong.
Exactly. And in more severe cases, you can even see psychotic features emerge.
Okay, that gives a really clear picture of what it is, a major impactful shift in mood, energy, behavior. But why does it happen? What'd your notes say about the etiology, the causes?
Well, the material clarifies that the exact cause isn't fully understood. It's complex, seems to involve multiple factors interacting.
What are the main players highlighted in the notes?
It points pretty strongly to a genetic component. So there's a hereditary link, a sort of predisposition.
Right.
There's also a focus on neurochemical imbalances in the brain. Specifically, it mentions neurotransmitters like dopamine and norepinephrine as likely contributing to the dysregulation you see in mania.
And external things, stressors and such, they play a role too.
Yeah, they're not excluded. Environmental factors and stressors are also noted as having an influence. They can trigger episodes or affect recurrence.
Okay, that makes sense. Which brings us naturally to risk factors. Based on this info, who might be more susceptible?
The risk factors are sort of grouped. A big one, which is non-modifiable, meaning you can't change it, is having a family history of bipolar disorder or other mood disorders.
Ties right back to the genetics.
Exactly.
And what about things people can potentially change? Modifiable risks?
Substance abuse is listed as a key one there.
Mm-hmm.
And again, similar to the causes, environmental stressors and specific triggers are also mentioned as increasing vulnerability. Knowing these can be really important for recognizing who might be at higher risk.
Yeah, it makes sense to link the why to the who.
Yeah.
Okay, let's get into the pathophysiology, what's actually happening inside the brain. The notes mention some interesting stuff from brain imaging.
Yeah, so even though the full mechanism isn't, completely clear, the material notes that bipolar disorder involves definite changes in brain function and structure.
Mm-hmm.
What's particularly highlighted are findings often seen in MSRA studies. The amygdala, which is heavily involved in processing emotions, like fear, excitement.
The emotion center.
Kind of, yeah. It tends to be hyperactive, overactive. While other areas, like the hippocampus, involved in memory and mood regulation, and crucially, the prefrontal cortex.
The decision-making part.
Exactly. That's key for executive functions, judgment, impulse control. Those areas often show hypoactivity, less activity than usual.
And you mentioned these specific brain changes help explain the actual symptoms people experience?
Precisely. The notes make that link. For instance, that hypoactivity of the prefrontal cortex could directly contribute to the impaired judgment, the poor decisions, the disinhibition you often see in mania.
Right, the recklessness.
Yeah, and meanwhile, the hyperactivity in the amygdala lines up with the really intense emotions and maybe heightened reactivity. It's fascinating how the brain circuitry seems to map onto the behavior.
That connection is really insightful, seeing how specific areas going, well, haywire translates to what you actually observe. Now, when someone presents like this, diagnosis isn't always simple. You have to rule other things out first. Your notes stress the importance of differential diagnosis.
Oh, absolutely vital. In clinical practice, you have to distinguish mania from other conditions that can look really similar. Your notes list several key ones to consider.
Like things caused by, say, substances.
Yes, definitely. Substance-induced manic episodes are crucial to rule out. Certain drugs can directly mimic manic symptoms. Schizoaffective disorder also needs consideration that involves a mix of mood symptoms and psychosis.
And physical health problems can sometimes look like mania, too.
Absolutely. The notes specifically call out hyperthyroidism and overactive thyroid. That can cause symptoms like high energy, restlessness, irritability, things that might make you think of mania initially.
Wow, okay.
And other general medical conditions that cause mood disturbances need to be excluded too.
So you need to be really thorough, make sure you're not missing something else entirely, just to help, keep those key differentials in mind. Maybe a simple reminder. How about Shalom?
Shalom.
Yeah, substance-induced, hyperthyroidism, other medical conditions, and maybe schizoaffective disorder. Just a quick way to remember the main mimics.
That's actually quite a useful mnemonic. SHO. Yeah, ruling those out is absolutely fundamental before landing on a mania diagnosis. Getting it right is the first step to getting the right help.
Okay, moving on to epidemiology. How common is this? The notes focus on the UK.
Right. The material states that nailing down the exact prevalence of mania itself is a bit tricky in the UK, partly because it's usually considered within the broader diagnosis of bipolar disorder.
Ah, okay. But we do have figures for bipolar disorder as a whole.
Yes, the notes give the estimate for bipolar disorder, which is thought to affect around 1% to 2% of the population in the UK.
1 to 2%. And when does it typically first show up?
The typical age of presentation mentioned is late adolescence or early adulthood. So yeah, that 1–2% figure for bipolar is the key takeaway here for prevalence.
Got it. Now, the clinical presentation section. This is where we get into the real nitty-gritty of what a manic episode actually looks and feels like, beyond just that core mood change.
Yeah, this section is detailed. It starts at that core requirement, that sustained period of abnormally elevated expansive or irritable mood. That has to be there.
Right.
But alongside that, you need 3 or more of the following symptoms if the mood is elevated or expansive, or 4 or more if the mood is primarily irritable. And these symptoms need to be present to a significant degree.
Okay, let's list those additional criteria. What are they?
Okay, so there's inflated self-esteem or grandiosity.
Check.
Decreased need for sleep.
Right, the energy thing.
More talkative than usual or feeling pressure to keep talking. Flight of ideas or subjectively feeling like thoughts are racing.
Okay.
Distractibility attention easily pulled away.
Yeah.
An increase in goal-directed activity, whether it's social, work, school, or sexual. Or just general psychomotor agitation, restlessness.
Gotcha.
And finally, excessive involvement in activities that have a high potential for painful consequences. Things like unrestrained buying sprees, foolish business investments, sexual indiscretions.
Risky stuff. Okay. Those are the core diagnostic criteria symptoms. Are there other things commonly seen that are mentioned?
Yes, the notes also list some related or additional symptoms you often see. Things like impulsivity, poor judgment. Euphoria can be the mood, or sometimes irritability is dominant. They also mention cognitive changes, like those grandiose delusions we touched on, overconfidence, disinhibition, and biological changes often involve that decreased need for sleep, and sometimes appetite decreases too.
And you mentioned psychotic features earlier as well.
That's right. The source confirms that in severe mania, psychotic features can definitely occur. These like auditory hallucinations, hearing voices. Or delusions, which could be grandiose, like believing they have special powers or a famous figure.
Okay.
Or they could be persecutory, believing people are out to get them. And the way someone speaks can be a clue too. Very rapid, pressured speech, hard to interrupt. and the content jumps all over the place. That's the flight of ideas.
Right. All these symptoms, the duration, and if these episodes alternate with depressive ones, that points towards bipolar disorder. Okay, keeping track of all those core symptoms for diagnosis, it can be a lot. Your notes mention a common mnemonic, right? Like dig fast.
Ah, yes, dig fast is a really handy one for remembering those core criteria symptoms.
Ah.
Let's see. Distractibility. Yep. Indiscretion, that's the reckless behavior.
Yeah.
Impulsivity.
Right.
Grandiosity.
Got it.
Flight of ideas or racing thoughts.
Mm-hmm.
Activity increase or psychomotor agitation.
Okay.
Sleep deficit, the decreased need for sleep.
Crucial one.
And talkativeness, that pressured speech.
Dig ice fast. That's a great tool. Okay, let's maybe test that with a quick scenario just based on what we've covered from your notes. Imagine someone hasn't really slept properly for, say, 6 nights. They're talking incredibly fast about these amazing but totally unrealistic plans. They seem absolutely convinced they're destined for great things, and maybe they've just blown a load of money gambling. What picture does that paint, according to these notes?
Okay, well, based on the duration, 6 nights of significant sleep change is getting close to that weak criteria for mania and that cluster of symptoms. You've got grandiosity, decreased sleep need, pressured speech, suggesting racing thoughts or flight of ideas, and reckless behavior with the gambling.
Yeah, that strongly points towards a manic episode based on these criteria.
Right, it's that combination and the severity, the impact. All right, so how do we formally investigate and assess someone presenting like this? Let's look at the investigation section.
Right. The crucial point your notes make here is that there isn't a single lab test, like a blood test, that can confirm a diagnosis of mania or bipolar disorder. It's fundamentally a clinical diagnosis.
Okay.
It relies heavily on taking a really thorough history, observing the symptoms carefully, and often getting information from family or friends to collateral history.
But there are tools that help with the assessment.
Yes, definitely. The notes mention various questionnaires and evaluation criteria that help structure the assessment. Things like the PHQ-9, that's mainly for depression, but often used as part of a broader mood assessment. There's the Mood Disorder Questionnaire, or MDQ, the Composite International Diagnostic Interview, CIDI, and something called the Bipolarity Index.
Okay.
And there's also the Young Mania Rating Scale, the YMRS. It's a really widely used scale designed specifically to assess how severe the manic symptoms are, usually based on the person's report over the last couple of days, like 48 hours.
Got it. And what about physical tests? You mentioned ruling out those other conditions earlier.
Exactly. That's where the screening tests come in. Their main job is to rule out those other potential causes, medical problems, substance use that we discussed under differentials.
Right.
So the notes list things like a full blood count, FBC, a thyroid function test, TFT, that's absolutely essential for checking for hyperthyroidism. Serum vitamin D is sometimes checked. And a toxicology screen, vital for picking up any substance misuse that could be causing or mimicking the symptoms.
Okay, so we can kind of group investigations. You've got the assessment tools, questionnaires, rating scales to characterize the symptoms, and then the screening tests bloods on screen to rule out other causes.
That's a really clear way to think about it, yeah. Covers the main types mentioned.
Okay, great. We've covered what mania is, potential causes, risks, what it looks like symptomatically, brain changes, how we investigate. Now for the really critical part, management. How do we treat mania according to this material?
Right. Management is presented as typically needing a combination approach. So pharmacotherapy, using medication alongside psychosocial interventions, or psychotherapy.
And if someone's in an acute, severe episode, maybe lacking insight, posing a risk?
Yeah, in that situation, the notes emphasize that urgent hospitalization might be necessary. For safety, aripiprazole and olanzapine are listed as first-line choices. They're atypical antipsychotics used for acute mania. Other useful options mentioned for the acute phase include haloperidol, which is an older typical antipsychotic, and lorazepam, a benzodiazepine often used for agitation or sedation short-term.
Okay. And what about longer-term treatment to prevent episodes coming back?
Yeah, that involves maintenance treatment, usually with mood stabilizers or sometimes long-term atypical antipsychotics. The notes list lithium, a classic mood stabilizer, really effective for many.
Right.
But it stresses the need for close monitoring. Blood tests are needed regularly because it has a narrow therapeutic range. Too little doesn't work, too much is toxic, and it can affect thyroid and kidney function over time.
Okay, requires careful handling.
Definitely. Sodium valproate is another mood stabilizer option mentioned, which also needs monitoring, particularly liver function. And then atypical antipsychotics like aripiprazole, olanzapine, quizapine, risperidone, they can also be used long-term. But again, monitoring is needed, especially for metabolic side effects like weight gain, diabetes risk, and sedation.
And does the approach change depending on how severe the mania is?
Yes, the notes indicate that for maybe hypomania or milder mania, monotherapy using just one medication might be enough. But for severe mania, a combination approach is often needed, typically a mood stabilizer plus an atypical antipsychotic.
Okay. And there's a really crucial warning about some of these medications, isn't there?
Absolutely critical, yes. The notes highlight the teratogenic potential of several medications used, especially sodium valproate and lithium. Teratogenic means they can potentially cause birth defects if taken during pregnancy.
Wow, that's serious.
It is. So, rigorous contraception is absolutely essential for women of childbearing potential taking these meds. And if pregnancy is planned or if it happens unexpectedly, specialist psychiatric and obstetric advice is mandatory. It's a huge consideration. Maybe a way to remember the key long-term types of meds is LAM.
Lamb.
Yeah, lithium, atypical antipsychotics, and mood stabilizers like valproate. Just covers the main classes.
Lamb. Got it. That warning is vital. Okay, what about management that doesn't involve prescribing? Non-pharmacological approaches.
Right. Well, in those acute situations we mentioned where someone lacks insight and is a risk, the notes mention that compulsory admission under the Mental Health Act, sometimes called sectioning, might be required. That's for safety and to allow necessary treatment.
Okay, a legal measure if needed.
Yes. And for relapse prevention, psychosocial interventions are really key.
And the notes specifically highlight psychoeducation.
Yes. Psychoeducation is described as basically a cornerstone of long-term management. It's about educating the patient, and often their family too, about bipolar disorder. What it is, the symptoms, recognizing early warning signs of relapse.
Spotting trouble early.
Exactly. And the importance of sticking with medication, strategies for managing stress, challenging unhelpful beliefs about the illness. The notes actually state that good psychoeducation can significantly improve functioning and even reduce how often people need hospitalization.
That sounds incredibly important. Are other talking therapies mentioned as helpful?
Yes. The material mentions cognitive therapy, family-focused therapy, which specifically helps families understand and support the person, and something called interpersonal and social rhythm therapy, which focuses on stabilizing daily routines like sleep-wake cycles, which can be really helpful in bipolar disorder.
So it's definitely not just about taking a pill. It's a much broader, ongoing approach.
Exactly. Ongoing care is essential. Regular reviews with a psychiatrist are needed to monitor symptoms, check how meds are working, manage side effects, support coping strategies, and just generally review how the person is functioning. It's a continuous process.
Right. With all these strategies in place, what does the prognosis generally look like for someone experiencing mania as part of bipolar disorder?
Well, the material offers a generally hopeful perspective with effective treatment. It states that many individuals can achieve stabilization of their symptoms and go on to lead fulfilling, productive lives.
That's good to hear. But it's usually understood to be a lifelong condition.
Yes, bipolar disorder is described as a chronic illness. Recurrent episodes, both manic and depressive, are characteristic. So long-term prognosis really depends on things like how consistently someone adheres to their treatment plan, whether they have other co-occurring conditions, comorbidities, and just the individual's unique response to the treatments.
Which naturally leads us to think about the potential downsides, the complications, if mania isn't treated or isn't managed well enough.
Yeah, if left untreated, mania can lead to really significant and widespread impairment. It can seriously damage someone's ability to work, hold down a job, maintain relationships.
Yeah.
It impacts personal well-being across the board.
And the safety risks we touched on sound substantial.
Oh, absolutely. Untreated mania can escalate. You might get those severe psychotic features, and this significantly increases the risk of self-harm, unfortunately suicide attempts, and sometimes even harm to others, often due to that impaired judgment and impulsivity.
And that reckless behavior itself causes problems down the line.
Definitely. That impulsivity and poor judgment can lead to a higher risk of developing substance abuse problems. Medical issues can arise from self-neglect or risky behaviors. People can get into serious financial difficulties from overspending. Legal troubles aren't uncommon, and there's a higher risk of accidents too.
So it's really clear that regular monitoring and proactive management aren't just about controlling the mood symptoms day to day. They're vital for preventing these really severe complications and helping maintain stability long term. We could maybe group those problems.
Yeah.
There's the impairment work, social, personal, the safety risks, self-harm, suicide, harm to others, and the long-term consequences, substance abuse, money, legal issues, physical health problems.
That covers the crucial negative outcomes the notes highlight. Yeah.
Yeah.
Really underscores why intervention is so important.
Okay. We've now worked our way through all the sections in your revision notes. We've covered the definition, causes, risks, how it shows up in the brain and in symptoms, how we investigate, manage it, and the long-term outlook and potential problems.
And digging into all this material, it does raise an interesting point for you to think about. Given that bipolar disorder is chronic and the risks of untreated mania are so significant, especially thinking about that impaired insight and potential for dangerous behavior, how does the information we discussed on psychoeducation and family-focused therapy really highlight just how critical involving support networks might be in managing this condition effectively over someone's lifetime?
That's a really great point to mull over. The ripple effects, the importance of that support system. Well, hopefully going through your notes together like this deep dive, has helped solidify those core points for your revision.
Yeah, we've tried to pull out the most important bits and make them memorable. Definitely review your own notes alongside this discussion. It'll help reinforce everything.
And remember, for more resources, you can check out pastthemsra.com.
And also, freemsra.com.
Thanks so much for joining us for this deep dive into mania.
Yeah, thanks for tuning in.
Until the next one.